So hello everyone, my name is Isabelle Jarrin and I'm a registered psychiatric nurse. Thank you to the college for asking me to present today, and sorry for the performance you just had in setting up the technical equipment. I thought it would be a little bit better to have some visuals to refer to because when we talk about studies it can get a little dry, so at least you can read along as I speak. So as RPNs we work in diverse settings, and like myself, those RPNs who work in acute care mental health know that we at times use seclusion as a form of restraint. And as an RPN, when I did work on the units, I always tried to use seclusion as less frequently as possible. I always tried other interventions, but there were times when I had to use seclusion. And I've always wondered, what is the best thing to do? Is it the best thing to do? And I struggled with that. When I moved into the role of nurse educator and I was teaching people about using seclusion and how to do it so that we are potentially not harming people, ourselves, the person we're secluding, I found myself saying, it depends. So when I'd have new staff, they would come in and they'd say, well, how do I know to use seclusion, or when do I know to use seclusion? And I had to say many times, well, it depends, and it depends. And it's all that clinical judgment that we use in determining when to use seclusion and how to use seclusion. And so when I started my Master of Nursing at the University of Manitoba, that was before the psychiatric nursing program had the master's program, I had to come up with a thesis topic, and I knew I had to come up with something that would keep me entertained and wanting to do homework on a Friday night for 4 years. And so I chose to look at seclusion, and I kept wondering how I could look at the topic of seclusion in a novel way and also answer some of the questions that I've had in explaining it depends. And so I approached Dr. Marie Edwards. She is a professor of nursing at the U of M, and her area of expertise is on ethics. And she was a really great mentor and supporter of my topic. Even though her expertise is in ICU, she was really able to guide me through the ethical aspects of seclusion and also of the research process. I also had Dr. Elaine Mordock, another nursing prof at the U of M who researches in mental health, and my external committee member was Dr. Merle Pauls, who is a ER physician and also a professor with the medicine program at the U of M, and his area of expertise is in ethics and bioethics. And so that was my committee who helped me along with my research. So the goal of my research was to explore the place of ethics in mental health nurses' clinical judgment in the use of seclusion. And what I'd like to do is link it back to our Code of Ethics and our Standards of Psychiatric Nursing. Don't worry, I'm not going to read the entire document to you. That's up on the website. But I will refer to it and show some of the linkages that exist between the work, the data that I collected, and our Code of Ethics and our Standards of Psychiatric Nursing standards. And at the end, there'll be time for some questions and your thoughts. And I know that this topic can engender a lot of discussion, but we'll be mindful of finishing by 5 so that the RPNF reception can start. So as RPNs, we do have a Code of Ethics and the Standards of Practice to guide our work. And this document states that the Code of Ethics articulates the ethical principles that values that guide all RPNs. The Standards of Psychiatric Nursing Practice further articulates the legal and professional obligations of the registered psychiatric nurse. So really, what our code and our standards want us to do is they want us to practice safely, competently, and ethically. And some of the pieces that I found that were relevant to my study were that we try and minimize harm, that we promote rehabilitation and recovery, that we recognize and address power imbalances, which is always a challenge, that we promote and maintain safe practice environments. So it's not just about ourselves or the person we're providing care to, but it's also about everyone in the milieu. We're also expected to engage in self-awareness and practice using therapeutic relationships, therapeutic rapport. So that's all fine and dandy when you read the Code of Ethics. I know when I was a student, I read it because we had to read it in some of our classes. And then when I graduated, I got the little booklet. And I put it aside and I thought, yeah, I think I do this. So how do we actually practice and put ethics into practice? That's the question that I wanted to try and answer. So several definitions exist for seclusion, and what I tried to do was pick the common themes that were in the definitions. Depending on the literature and where you look, you will see differences. And so for the purposes of my research, I used the definition of an intervention where clients who are a danger to themselves or others are confined alone in a locked room from the outside. And as we know, in mental health acute inpatient settings, seclusion is used for the management of disturbing patient behaviors, but some have written that it's also violating of human rights. We also know that mental health nurses, so RNs, RPNs, are the ones who are often called upon to make that decision to seclude someone. There might be a physician's order or one that's obtained after the fact, but oftentimes it's that RPN who's saying, okay, we're going to use seclusion. Some researchers have talked about how there's an ethical quagmire that exists in determining when to use seclusion. And what we have to balance are the principles of autonomy, beneficence, and non-maleficence, along with the therapeutic goals. So we're trying to protect the person, protect others, but we're also trying to not harm the person and to not put a rupture in that therapeutic rapport that we have with the person. So guidelines for seclusion use have been created, and there's many that exist around the world. And they provide criteria for when and how to use seclusion to guide both the institutions and the staff using seclusion, and also to protect the person who's being secluded. What the research shows is that rates of seclusion vary globally, and they've been reported as low as 0.25%. Some countries don't use seclusion, they use one-to-one nursing, and as high as 66%. What's interesting is that there are no globally recognized standards for measuring and reporting seclusion, including here in Canada. In looking at the literature that talks about seclusion, and I just want to comment that I look specifically at seclusion. Seclusion is a form of restraint, and there are many articles that also talk about mechanical restraint, but I really tried to hone in on seclusion as a form of restraint just to keep it a little bit more manageable. I looked at literature that talked about nurses' attitudes and their feelings towards aggression and seclusion, and what was seen was that nurses felt that seclusion was a necessary intervention, and that they felt that it was often used due to patients' aggression, either towards the patient themselves, other people on the unit, or towards the staff. There's been a body of literature that's been developed looking at the patient characteristics. So is there a certain diagnosis that's more associated with seclusion, age, gender, that sort of thing? So what the literature is showing is that usually it's younger males with a diagnosis of schizophrenia or bipolar disorder who are the most frequent users of seclusion, or who are most frequently put in seclusion. There's also been research that looks at patient behavior. So what are people doing prior to seclusion to require the need for seclusion? There's also been a very limited amount of research that's asked patients themselves what they felt about seclusion. And it's interesting because it varies. So some patients say that they felt that they needed seclusion and that they thought it was therapeutic, while others said it was totally untherapeutic and a punishment. And they didn't know why they were secluded, and they didn't understand, and that it caused trauma. So again, a lot of variability there, and that's a rich area of research for anybody who's interested in doing that in their psychiatric masters, psychiatric nursing masters. There's also been literature that's looking at seclusion reduction strategies. So for example, the program in the US on the 6 core strategies for reducing seclusion and restraint. There's other programs as well around the world. And there's been a little bit of literature talking about the ethical dimensions of seclusion. Where the gap exists is that there's actually an incongruity between the use of seclusion and its therapeutic value. If you look at the Cochrane report on seclusion, there's no RTCs that have been done on the use of seclusion, and they actually say that there's no therapeutic value to seclusion, but they say that it has to be done judiciously until more evidence is brought forth. There's also the acknowledgement that seclusion is a coercive practice, and we're restricting someone's autonomy and their rights. And so we have to be mindful of that. How does that look to someone from the outside? There's also been limited research examining the ethical dimensions of this as an intervention. What I found really interesting was I would read an article that talked about seclusion, and it would say there's ethical considerations to using seclusion, and that would be one line, and then it would talk about the whole study, and that was it. There was nothing else talking about actual ethics of using seclusion. And so that's where I really wanted to focus to help me answer the question, it depends. The purpose of my study was to explore the place of ethics in nurses' clinical judgments related to seclusion use. And again, recognizing that mental health nurses are often the ones who are making that decision. So that's why I wanted to focus on that group. It's not to say that when we work collaboratively and we work with many different disciplines on the unit, and so there are times when it's not just that one nurse or a group of nurses making the decision, it's many people. But I wanted to try and put some parameters on my research, so I focused specifically on mental health nurses. My research questions were, what are the mental health nurses' experiences with the use of seclusion in inpatient mental health settings? What are the mental health nurses' perceptions of the factors that influence the judgment to seclude a patient in mental health? And what consideration is given to the ethics of the practice when secluding a patient? So the conceptual framework that I used was a clinical judgment model created by Tanner. Tanner is a researcher in the U.S. Who's worked extensively with Patricia Benner on the novice to expert body of literature. And she was interested in looking at a model that could be used for teaching nursing students about ethical decision making and how to practice ethically. And her definition of clinical judgment is an interpretation or a conclusion about a patient's needs, concerns, or health problems, and or the decision to take action or not, use or modify standard approaches, or improvise new ones as deemed appropriate by the patient's response. Her model is actually quite simple. This is not the exact replication. If you look in her article, it's a little bit fancier. But what it talks about is 4 areas. And so she says that nurses move from noticing. So they will identify that something's happening and in a situation, and that it's important for the nurse to do something about it. And so that moves into interpreting. So the nurse is using his or her body of knowledge, previous experiences, the knowledge of the person, the situation, what's happening, to make a decision on how to move forward. And that moves into responding. And so in the area of responding, the nurse is using appropriate interventions and trying them out. And then it feedback with a reflection. So a reflection in action. So as a nurse tries something, there'll be an immediate evaluation. Is this effective? Is this working? And so then it goes back to the interpretation. And if it isn't, then the nurse will try something else and again move back to interpreting and responding. But then there's also a reflection on action, and that happens after the fact. And so when you think about seclusion, there's in the moment, okay, is this working? I'm going to try this. And sometimes it's very quick and it's unconscious, really. But then after the fact, there's that, oh, yeah, I don't feel good about this, or this happened, or that happened. I should have done this. I wonder if we had tried this. So there's that reflection on action. So I thought, although it wasn't specific to mental health or psychiatric nursing, I felt that it did fit my purposes quite well. I also used the clinical judgment model to inform the interview questions so that I guided the nurses who I interviewed through that process of noticing, interpreting, responding, and reflecting. I also used it in the early codes for the data analysis. So I engaged in a qualitative study, and I used Sally Thorne's interpretive description as a research methodology. And of course, I received approval through the University of Manitoba Education and Nursing Research Ethics Board. I was fortunate to have the CRPNM and the CRNM agree to send out notices to RPNs and RNs who work in acute care mental health so that I could recruit participants to my study. The criteria I used was RPNs and RNs with a minimum of 1 year experience in mental health within the last 5 years on an acute adult mental health unit where seclusion was used. I had a lot of interest from people who said they hadn't worked in mental health or in acute care mental health in 20 years, and it was very great. It was nice to hear from them, but I had to turn them away. I wanted to have some people with some more recent experience. So I conducted face-to-face semi-structured individual interviews. They lasted approximately an hour. Some were a little bit shorter in time, some were a little bit longer depending on the discussion that happened. The interviews were audio taped and transcribed by me as well as 2 professional transcriptionists. I started to do it and then I realized that to meet my deadlines I had to get a professional transcriptionist. I also took field notes and I kept a reflective journal, which are all part of Sally Thorne's interpretive description methodology. So in terms of data analysis, I used interpretive description, and I also used NVivo software to help manage the data. And it was quite helpful because I was able to do line-by-line thematic analysis and identify codes and identify areas that were similar. So I looked for similarity between the narratives that the nurses were sharing with me. I also used contrary cases, so something that was quite different for one participant, and that would be highlighted. And I had several meetings with my advisor, with Marie Edwards, and she was also analyzing the data. And so we were meeting to make sure that there was some congruity between what I was finding and what she was finding. And so that's how we tried to keep the true to the data. So my sample consisted of 17 nurses. There were 9 RPNs and 8 RNs who worked in acute mental health. There were 13 women and 4 men who participated with an average age of 44 years. And on average, they had about 17 and a half years of mental health experience. The RNs had worked elsewhere, and so they had additional years there. And the years of experience ranged from 2 years to over 30 years. So real wealth of information and a nice range between the nurses who I interviewed. So what I thought I would do is give you some of the findings in response to the 3 questions that I had. In the 3rd question, it's the 2 broad themes that I identified. So in terms of the findings for question 1, the experiences with the use of seclusion, all of the nurses were able to describe a situation where they used seclusion. And there were about 45 episodes of seclusion that were described by the participants. Sometimes several seclusion episodes were discussed in an interview, and at times it would be one main seclusion episode that the nurse kept referring to. And they described them. I asked them to describe whether the seclusion episode that they were talking about was typical or atypical. So for example, a typical seclusion episode would be the patient's behavior was escalating and that patient's aggression posed a risk of harm to self or others. Another example was placing newly admitted patients, if they had a recent history of violence, they would be placed in seclusion upon admission. That some nurses identified that as typical. Some nurses identified atypical situations, that ones that involved a significant event like a staff member being hurt, a staff member being unintentionally locked in the seclusion room with a patient, or a patient being carried to the seclusion room, so varying away from hospital policy. So I have a quote. One nurse described an atypical situation as, "Yeah, that was completely bizarre, but it wasn't really unusual for someone to get hurt in the process. As the cause of the seclusion episode or in the course of the seclusion episode, it wasn't that unusual. Sometimes it's that someone has been injured, but more often than not, it's in the process of seclusion because it's more like all bets are off depending on how it's going. So if you feel ganged up on, then you are more likely to fight back. It's what I've seen." Some nurses described atypical situations to be one where the patient's medical or psychiatric condition was impairing his or her judgment, and so the patient had to be secluded to maintain their dignity and their privacy, and also to prevent other patients from being physically or psychologically harmed. Here's a quote from one nurse. "I can remember one time secluding somebody who was delirious, and the decisions I made around that were because the person was confused, of course, with delirium, was wandering into other people's rooms. That in itself did not make the decision to seclude the person, but they unfortunately were stripping and would not keep their clothes on. So at that point, it was like, how can we protect this person's privacy because they are delirious? And when they aren't delirious anymore, they realize what was happening. How would that impact them at that point? The nurses also discussed a growth over time in their personal confidence regarding their ability to advocate for their patients and to clinically assess their patients with regards to the need for seclusion. One nurse described this growth in the following way. Well, when you first start your career, you tend to follow the pack, and so you do what your more experienced peers do, and you'll often ask them for guidance, and then you'll follow their direction, or you'll learn by watching. But over time, you sort of have to develop your own approach, and you come to realize what you feel, what your own comfort level is with seclusion and using seclusion rooms. And so over time, I have become, I think, more and more lenient and more sort of tolerant of behaviors that may have warranted seclusion in my mind in the past. And so time and experience and confidence, really a lot of it has to do with confidence that you're not going to be judged negatively if you make a decision. And even if you are, and then you're able to handle it, you're able to cope, to deal with opposition from other staff. The nurses also talked how they felt that there was a perception that seclusion was used less frequently than when they had first started working on mental health units. All but one person actually felt that seclusion was being used more frequently now. So it's an interesting observation. The last commonality was that the nurses felt that seclusion was used only as a last resort and after other interventions had been attempted and if the patient was going to injure himself or herself. It was based on the patient's clinical presentation, whether the nurse felt discomfort in using it due to personal experience, and that they recognized that it restricted the patient's freedom. So that's why they felt that seclusion was used less frequently. In terms of question 2, the perceptions of the factors that influence the judgment to seclude a patient, the nurses talked at length about there being 3 areas that they considered. One was patient factors, the other unit factors, and lastly, their own factors, nurse factors. So I won't go into detail about each one, but the patient factors were things like what the person was doing, what was the risk of harm, were they going to harm themselves, harm someone else, harm the staff? What the past history was of aggression or violence, or how did the person behave if they knew the person that they might calm down. Oh, that's just so-and-so and I know he'll calm down, so I'm not going to use seclusion. Or I know so-and-so and he won't calm down, so I have to use seclusion. They also talked about the current mental status and was a person able to think rationally what was going on in that regard. The nurse factors were their experiences as a nurse, so what they had experienced in the past, maybe with that patient, maybe with different patients, their level of skill in using seclusion or de-escalation techniques, their education that they had received. Many talked about learning new ways of dealing with seclusion and de-escalation, and that assisted them. Many had the philosophy or the attitude that they were using this as a last resort and that it wasn't something that they enjoyed using. They also talked about their assessment of danger, and some of how they did that was assessing their own level of fear. So not to say that they responded because they were afraid, but that if they were really afraid, then something must be going on and I need to do something about it. And they also talked about the use of the therapeutic rapport, how they were able to engage with the person to either try and avoid seclusion, or even if they had to use seclusion, to reestablish that therapeutic alignment with them afterwards. The nurses also talked about the culture of the unit and how sometimes you worked with certain people and it was expected to use seclusion, and other times when it wasn't, they knew that they could try other things and it wasn't an expectation. Things like who you were working with on that shift. And I know for myself that's been an issue too. So the nurses talked about that. They also talked about referring to things like policies, procedures, guidelines to help them inform their practice. So a quote from one nurse: "There's no kind of algorithm for how I would handle that. It would depend on the person. It would depend on the situation. It would depend on if I went up to them and I knew that would be more agitating than I wouldn't. And so that's how you get to know patients. And that's when clinical judgment comes in. And so if it was a patient I just met, I wouldn't know that. So I would try my best based on the moment. But if you have a patient who's been on your unit for 6 months and you know that what makes them tick, then you don't react. Your reaction is going to be different based on how you know they react. Well, you're going against what the group is doing, so you're pitting one person against each other, and that's a big no-no. You don't, quote, split. You have to stand up to that, and so that can be very, very, very hard, and sometimes you're just exhausted. You just go with what the group says, and I don't like it at all. It doesn't feel right. It feels very wrong because I'm a nurse. I'm supposed to be protecting somebody's dignity and their human rights, and I'm not when I just sort of go with the group. In answer to question 3, the consideration of ethics when secluding, the next few slides are going to highlight the definition of ethics that the nurses had, the ethical tensions that they felt, as well as the 2 broad themes that were identified from the data, the complexity of promoting safety and the importance of knowing for good and ethical practice. So in terms of the definition of ethics, what came clear was that there was a capital E ethics, so the formal ethics that you would, do in your exams or in school. And there was also the little e ethics, those everyday things of what's right and what's wrong that not necessarily captured and that we don't think of as ethical. And the nurses really showed that in their definitions. So for example, one nurse described ethics to me is to do no harm or least amount of harm, even when the action is to shut off the machine that may be keeping someone alive. Another participant said, I think ethics is, that's what I always call like the capital E ethics, and I just think about all of the things that happen every single day that are in the ethics realm that we don't call ethics. So if I'm talking about putting someone in a room and locking the door, there's all kinds of ethics. The nurses talked about ethical tensions that they felt. I had already mentioned this. There was pressure from the team and co-patients to seclude. They also talked about uncertainty in terms of the risk of harm. So one person might say, I think there's a risk for harm, whereas someone else would say, oh, I don't know, I don't agree with you. They talked about sometimes seeing seclusion used as a punishment, and that didn't sit right for them. And they also talked about the idea of getting it wrong or getting it right. So the idea of getting it wrong was when seclusion had been used in the context of not following policies or protocols. So that example I gave before of carrying a patient to seclusion when it was contraindicated. The notion of not intervening early enough. They felt that that was getting it wrong. And so they wonder if they had intervened earlier and tried to de-escalate the person, or if they had tried some type of intervention early on, could they have avoided using seclusion? For example, one nurse reflected on a seclusion episode and stated, we probably could have intervened a lot earlier because he was getting agitated, retrospectively when I look at it. The first theme I identified was the complexity of promoting safety. And so this came up with the very definitions of harm, including various types, so physical, psychological harms. The nurses also talked about how others around the nurse defined harm. So again, having to navigate that and determine if they were on the same page or not. They also talked about whose safety had to be considered. So it wasn't just the patient. It was the patient, the other patients on the unit. It was the staff. It was maybe visitors or family. And that was really complex for them. They talked about their past experiences with violence and harm and how that would enter in. And so they talked about having to maybe put that on hold or having to pay attention to that so that they weren't re-injured and have a bad experience. The nurses also talked about their confidence in the assessment of risk. And so they really had to feel confident that what they were doing and deciding was accurate. Were they doing the right thing? And linked with that is the trust of their own decision, the trust of the patient. If I don't seclude the person, can I trust that they will stay calm, or will they escalate further and need seclusion? Can I trust my team? So if I make a decision, will my team back me up, whatever that might be? The complexity of promoting safety is also in terms of the threshold of seclusion. So on this graph, you'll see that on the left-hand side, it's moving more towards avoiding seclusion, and then as it moves to the left, and as it moves to the right, it's moving towards seclusion. So the nurses talked about the need to know the patient, to really have an idea of what ticks them, makes them tick, what ticks them off, what helps them calm down. Did they have a good rapport with the person? Were they able to use themselves, that whole idea of therapeutic use of self? Did they trust the patient, the team, their judgment? Did they have support from the team? And they found that those things helped to avoid seclusion. When they moved towards seclusion, it was more because there were concerns about their safety and the risk of harm. There was fear that somebody was going to get hurt or further hurt. There was sometimes pressure from others. I need to seclude. And of course, the last one was imminent risk of harm. And that was, somebody was going to do something that would either extremely injure them or cause irreparable damage. So one nurse quoted, "Well, just that. And again, we tend to seclude, I would say. It's not a quick decision, but it's usually something that we can anticipate is coming, but are trying to avoid. So if we're getting to that point, you wrestle with it inside yourself. Is this the best option for the patient? Am I hurting them more by putting them in there? Is it horrible to have to get them changed into hospital PJs with 60 people standing in a room? 60 is a bit of an exaggeration, but..." So those are kind of ethical things, Giving someone medication against their will is an ethical issue. Another nurse shared, "And for me, early on in my practice, it would have been my preference not to have ever put someone in seclusion. But in situations where I felt like I didn't see us as having another choice, was that the threshold was that the person was imminently causing themselves serious harm, or imminently it was very apparent that they were actually quite threatening to somebody else. They had either actually started to physically assault somebody else, or they had started to physically harm themselves in a way I didn't think that there was any other option but seclusion. So to me, the threshold was I was really, really, really concerned about their own personal safety, or I was really concerned that they were going to hurt somebody else, whether it be a staff or another patient." One nurse said, "I saw people getting hurt while they're being secluded. And so for me, something is wrong here. We have to be doing something different. We have to be doing something wrong, so we need to try something different." I asked, "And would the patient become injured in that process?" The participant said, "Not a lot of times, surprisingly, but yes, when you say injured, okay, well, physically injured, but emotionally, that's a whole different story." The second theme that was identified was the importance of knowing for good and ethical practice. And knowing involved several areas. So there was knowing themselves, so the nurse knowing him or herself, knowing the patient, the team, knowing who they had on their side, who they could trust, knowing about alternatives and options, so that whole idea of education, and knowing what the impact of seclusion meant on the person. Were they affecting the person's dignity? Were they re-traumatizing the person? So one nurse says, "It is absolutely true that if you engage people and have conversations with them, be it over a pool table or over a desk, both parties benefit from that, both short and long term. I think what you need to do personally is go back to Nursing 101 about being non-judgmental, being empathic, spending time communicating in a therapeutic manner with these people." It seems pretty basic. But I think that's something that maybe has been lost or needs to be found again. Another nurse said, "I use a lot of humor. I try to put myself in their position. I try to be real, understand what they're going through, and say to myself, what would I need to hear if I was in their situation right now? That's what I do." It's a bit of a longer quote, but I felt it was very important. One nurse commented on how the therapeutic use of self involved a cognitive and emotional, yet rewarding element to the nursing care involved in de-escalating a patient. It's emotionally draining because what your first instinct is, if they're so agitated like that, you want to put them in a room or send them to their room. That's the first instinct that you'd want to do. But it's exhausting because you have to put yourself out there and be vulnerable. And you're vulnerable because you do not have all the answers and you don't know what is going to be coming up next. So you have to spend time with the patient while they are upset, angry, crying, screaming, and you've got to stay with that patient. And you're thinking all the time, what am I going to say next? And what am I going to do next? Because you've got a plan, and so you've got to go along with according to what the patient is saying. So it's an emotional roller coaster in a way. It's much easier to seclude them or give them medications. It's much easier. This is more difficult, but in the end, this pays off because that patient knows, even when they're sick, that you've helped them through that difficult period or time in their day or their life at that time. And I think that is very rewarding. So I think that comes with practice, and I think it comes with you're leaving yourself open as a human being because you're talking to another human being who's really struggling. So, to bring it back to our code of ethics and our standards of psychiatric nursing practice, I think that the nurses who I interviewed really shared a concerted desire to try and practice safely and ethically. They talked about trying to provide safe, competent, and ethical care. They talked about trying to minimize harm. They also spoke about how they would, not specifically, but that whole idea of rehabilitation and recovery. They talked about power imbalances and their wish to promote a safe practice environment. And one thing I was really struck by was their desire to talk about self-awareness and the therapeutic relationships and that whole idea of therapeutic use of self. So I think in answering the question of what is the place of ethics in a nurse's clinical judgment to use seclusion, it's about being purposeful about the use of seclusion. And it's about trying to promote safety and using knowledge of the patient, the unit, the situation to inform your judgment in order to ethically justify the use of seclusion or quote unquote get it right. I'd like to thank all of the nurses who participated in my study, the RPNs and the RNs who gave of their time. There was no remuneration for my study. I didn't have funding for that. And I was also trying to balance that whole ethical piece. So I was very cognizant of their time. And also to the CRPNM and the CRNM who sent out the invitations on my behalf. I also am very appreciative to the support I got from my thesis committee. Marie Edwards especially, she spent a lot of time with me going through the data, and I showed her the presentation I was doing today, and she said, I'm really struck and reminded about the importance of looking at ethics in mental health care, even though she's an ICU nurse and that's her world. So she really appreciated that. So I'm wondering if there's any questions. Yes.
Hi, this is the second time I've heard you, and I appreciate it even more the second time around.
Thank you. You came to my thesis defense, so, not a high-stress day or anything, yes.
Again, so much information about this. What are your thoughts about how you can use now your results to impact psychiatric nursing practice, let's say, in the facility you're at? Give some consideration to how you can unfold this and possibly use some of this data for impact on practice?
I think so. The timing right now is we're rolling out the 6 core strategies for reducing seclusion and restraint. And so I have Benita here, my colleague, who we're teaching the course. And one of the things we've been really trying to focus on is how are we engaging our clients and working through that staff fear and anxiety to try and find alternatives. So really it's about how you get to know the person. So I'm not showing them this presentation because they probably would fall asleep, but that is what we're focusing on. Yeah.
So you're using, because the data really brings it back to the therapeutic use of self and with the patient. So that's what the 6 core strategies are focusing on. Kind of.
Yeah.
Very nice.
Yeah.
Very nice.
Thank you. Yes.
I have 3 questions. I think they all fall under one question. That it doesn't seem to be mentioned in your presentation, and that's the ethical dilemmas around when seclusion decisions are made for staffing reasons, low staffing reasons. So for instance, at one point, a reason for seclusion was given the person was secluded on admission with a past, if they had a past history. And then it's contradicted by saying we only use seclusion when there's imminent danger. So in my own past practice, that was often, I think, the ethical dilemmas. And when people talk about the use of the therapeutic use of self, did they talk about whether nurses or whether managers were able to staff one-to-one expert nursing attention to someone who is escalating and trying to avoid seclusion?
Those are really great questions, Karen, and I agree with you. I know in my own practice I've seen that. However, I had to go with what the data that I collected, and so it was really interesting that the nurses didn't go back to that. When they reflected on their seclusion episodes, that wasn't something that they focused on. They didn't mention the whole idea of staffing, which is really interesting. There could be a variety of reasons. It's what they thought of in the moment. It could be the interview questions that I asked. I asked about a time they decided to use seclusion. So maybe if I had asked the question of, was there a time that somebody else decided to use seclusion and it wasn't based on your own decision? So yeah, it is interesting. There's a lot of room to explore with this, definitely. Yes.
I have to tell everybody, I'm so proud of Isabelle.
We are too.
I told her first psychiatric nursing
Thank you, Beverly.
I'm going to say one of the first things when I was teaching the introductory psychiatric nursing was to talk about therapeutic use of self. And I'm glad to hear you remember that.
I haven't forgotten it. I speak about it ad nauseum, and so people know. Renee had to hear it recently, and I kept talking about Hildegard Peplos, so it stuck with me, Beverly. I remember.
But the other question I was going to ask, you make no mention of at what point does medication become effect, or was that something you maybe didn't look at? But
yeah, I didn't look at it. One participant, I do recall, one participant talked about how sometimes if the person is not at a therapeutic dose in terms of their medication, that there might be symptoms that are coming up. And so the whole idea of medicating appropriately to manage symptoms. But I didn't want to get into that because chemical restraint is another form of restraint, so using PRNs and that kind of thing. So I tried to keep it, but I left it open. I mean, nurses could have talked about it, but that wasn't something that really came out. It's a good question, though. Yes?
I'm curious about the nurses who were on the lower end of the spectrum in terms of years of experience and kind of fighting that battle of knowing that you don't have a lot of experience and wanting to learn from those who do, but then also at the same time maybe questioning how those individuals are using seclusion and sort of maybe the culture of the unit. And I'm wondering if they spoke at all about how they kind of navigated that kind of tug of war between.
Yeah. I can't make direct causal linkages and about age and practice, but what was interesting was some of the literature shows that the more experienced staff will be less inclined to use seclusion, whereas younger nurses would be more inclined to be restrictive. And I didn't see that. And again, I can't say because it was only a sample of 17, so the 17 people I interviewed, but definitely there was a sense that it was just about trying to do the right thing at the moment. And so many of them talked about that struggle of having to say no to using seclusion or not feeling right about using seclusion, or how they made that decision to seclude. So and again, it could just be who presented to be studied, right? It would have been interesting to hear from people who maybe think that seclusion should always be used. And I'd love to hear the rationale for that, right? I'd love to hear that and study that, but that wasn't who presented. Mm-hmm.
Thank you.
Yeah. Any other thoughts or comments? Thank you very much for your attention and for sharing. And I think we're going to pass it on for the foundation reception. Thank you. So I just